You might think maybe I'm not a genuine Bangladeshi, but I have been living there and working in population and health research since about the beginning of the MDG period, since about 1991. So it's been a very interesting period, and you've already seen, but you'll see a few more examples of what's changed in that time. And it has not been a linear change. So I'll just mention one of my colleagues here who worked on this, but there were a team of us actually who've worked on a number of these findings. Okay, and apologies if you've already seen this graph, but there are some elements to this which are also worth repeating, I think. So we have this mysterious figure at the beginning of the MDGs of 574, and none of us know where that came from, but it was created for the purpose of the MDGs. It's probably about right. It's probably about right, maybe slightly optimistic. And it comes from a committee, so it must be, it's the best we can do. So we're looking at a target over here of about 143, the usual thing. And we've got two pretty solid surveys, which most countries don't. If you see this graph here, you've got 9 countries there, I think, which are said to be on target to achieve MDG 5. I think there's huge variability in the quality of the data to come up with these estimates. And as you know, maternal mortality is a rare event compared to under 5 mortality, so you need a very large sample. This survey here in 2001, we used 100,000 households, which was at the time about 7 times larger than the average demographic and health survey. Cost about $1.8 million. This one, because we're trying to detect a significant change over time, that was much larger. It was 175,000 households. And on January the 1st next year, we'll go to the field with the third BMMS national survey of 310,000 households, about $4.5 million, which is a lot of money to find for basically a single cause event, although a whole lot of other information is obviously gathered in that. But the slope is looking good. We still need, from 194 to 143, still another 25% decline in MMR, which translates to about 2,000 maternal deaths. We have to find reduction in another 2,000 maternal deaths, which I think is possible. Just a little background on the maternal health strategy. I wonder, can we dim these lights a little bit, this one? No, you can't, okay. Okay, well, you've already heard a little bit about how health services evolved in Bangladesh, and from the beginning, really from when Bangladesh separated from India, there was the usual kind of pattern of a small number of rural health centres and a large number of fairly low-level workers who had limited training. Maternal child health services were delivered through a large number, about 1 per 4,000 population of family welfare assistance for the government, and the use of traditional birth attendants, which was tried in a lot of places. You remember at that time, risk identification was the key. So you can train workers like that to identify risk, which is early age of childbearing, or high parity, close intervals, previous negative history, and that kind of stuff. So teaching risk identification was pretty straightforward, and then delivery of iron folate tablets and a few things like that. Family planning, they delivered pretty effectively. As we all know in the late 80s, that reliance on traditional birth attendants was kind of failed, basically, because they just didn't do enough deliveries to maintain their skills. And in fact, quite a few of them were still practicing some of the bad practices, like yanking on the umbilicus to get the placenta out and stuff that just didn't change their practices. So that was abandoned at that time. So we had a problem then. Around 1990, we had about around 10% of women getting at least one antenatal visit, which was also a bit paradoxical because, as John mentioned in his introduction, tetanus toxoid was hugely popular. So pregnant women would go and get tetanus toxoid vaccinations all the time, but they would not go for any other antenatal service, which always seemed a bit strange to me. But tetanus is such a striking disease and such a horrible way to die that I think everybody knows that if there's any way to prevent a tetanus death, you do it. And then in the late 80s, we saw the abandonment of the risk approach and a switch to the 3 delays. But the 3 delays really require the construction of facilities. So there was a major push between 1990 and 2000, so the beginning of the first decade of the MDG period here. And as Professor Kovadia mentioned in the morning, these things are not linear. They increase after 2000, I think in South Africa and also in Bangladesh. So we had a massive investment in upgrading of district hospitals, medical college hospitals, maternal child welfare centres, which had been neglected, almost non-functional, but were interesting because they were almost entirely staffed by women. So it was relatively easy to upgrade them, and then they became remarkably popular for a while. Not so much now. And then sub-district health centres, just a small number of them for EOC. So there was a massive investment. The target was to achieve the 4 basic EOC facilities and 1 comprehensive EOC per 500,000 population. You can see here that was nowhere near achieved by the turn of the century. And there was a lot of talk about what is wrong with these people. We provide these nice upgraded facilities for them and they don't come. They don't use them. And there was a lot of despair in the medical profession that it was a waste of time upgrading facilities for women to deliver. Okay, and you can see on this graph, I'm just using the demographic and health surveys, of which we've had 7 now, I think. Along here, the yellow bars are the proportion of deliveries attended by skilled personnel. Now, a small proportion of those are skilled personnel delivering at home, but mainly it's in a facility. But it was pretty much flat here around 1 in 10 until 2004. Now, it started to kick off then and has been rising steadily. We've got another DHS coming out, as Sham said, in about 2 weeks, which is going to be around there. But it looks promising that it's increased, but it's still only 1/3 of all of all deliveries in a facility. So we've still got a long way to go before we get substantial rises. And I think Victoria will maybe highlight some of the differences between Africa, where you have very high rates of facility delivery, but also high rates of maternal mortality. So we have this puzzle. How do we get a reduction in maternal mortality with such low rates of facility delivery? I'll just mention something else which I'd kind of forgotten about, but around here the government program switched from project-based to sector-wide approach in 1998. We started the first. It was only the second country, I think, to really introduce a sector-wide approach in the health sector after Ghana. And it has made a difference, but it took a long time to get organised. But we're really starting to see now, we're just finishing the 3rd 5-year sector-wide approach, and it's starting to make an impact on the efficiency of service delivery. Now, okay, so what were those green bars are now down here. These yellow bars are just at least 1 antenatal visit from a medically trained provider. And you can see, even when facility delivery was very low, back here in the 90s, the use of ANC had picked up, but it's still only about half of women get at least 1 visit, so it's nowhere near the kind of targets that we're looking for. But it was acceptable. It became acceptable for pregnant women to go for ANC visits, but not to deliver, even though that was part of the messaging was, please deliver your baby in a facility. They didn't do it. Now, maternal health services have always been the most inequitable of any of the health services or family planning services in Bangladesh. And the ratio has nearly always been around 10 times. So remember in the DHS we divide the population in survey into 5 groups of 20% each, from poorest to richest. Some people don't say richest because it's all relative, but the better off group here. Now you can see here in 2001 only 3% of the poorest had used a health facility for delivery versus 30% of the richest quintile. So going from a very low base, you've gone from 3% to 8%. So the inequity reduces, so the difference between the yellow and the orange bars is reduced to about 7, 6.5, 7. But from such a low base that it's not something to be satisfied with at all. And the percentage increases, this is increased by 5 percentage points among the poor and 23 percentage points among the richest groups. So the increase is greater among the richest, even though the inequity appears to be reducing. So we still have a massive problem with inequities in maternal health services. Now, the question is, what's going to happen in the future? And we're talking about reducing these inequities, but many of us see these inequities increasing, because you'll see here, this is the 2001 survey, both in urban and rural areas. The majority of deliveries in a facility took place in the government sector, the yellow boxes here, so 12%, 4%. The private sector was there, but that's leapfrogged over the public sector in the last decade. in both urban and rural areas. And this is quite worrying because the private sector is distorting the whole picture in a way that is something we should be really concerned about. And I'll explain more about that. I'll come back to that in a moment. Okay, so what else has happened? Fertility, as John said, fertility's declined pretty impressively. In fact, this figure's a bit low. It was up around, historically around 7 children, but we're now down to pretty close to replacement level fertility. There was a plateau there during the 1990s, which we've now overcome, but we may be facing another one. So we're trying to get down to replacement level fertility here. Now, this means that the absolute number of births has also declined dramatically. And as you know, if you don't get pregnant, you can't be exposed to risk of maternal death. So, and we're looking at the future, even though we'll see in the next 2 decades, we'll see an increase in the number of women of reproductive age of about 10 million increase. But the number of births will drop from the current 3 million a year to about 2 million a year over these 2 decades. So that alone plays a role in reducing maternal deaths. It doesn't play a role in reducing maternal mortality ratio, which is maternal deaths to births. Okay, so fertility's gone down in fairly encouraging ways and reduced the number of births and number of women at risk. We played around with this and did a bit of a decomposition between the 2001 maternal mortality survey and the 2010. In 2001, we had about 12,000, a little over 12,000 maternal deaths a year. If nothing had changed in terms of the risk and the age pattern of women of reproductive age, then we would expect by 2010 to have had about 14,300 maternal deaths per year. In fact, we're down around here, about 7,000. This is a bit crude, but you can do some of these kind of decompositions. About 21% of this total bar here, the reduction there of these missing deaths or absent deaths or avoided deaths was due to decline in birth rates. Some proportion, 7%, due to change in age at parity because there's a bit of a shift. And as you know, maternal mortality is not a linear thing with age or parity. It's exponential. So we've reduced a number of the high parity and older age births. One of the problems is we still have very early marriage, very early initiation of childbearing, and a larger proportion now of our births are in that risky period, teenage childbearing. And then there's some reduction in the age and parity specific risk of maternal mortality. So the risk of maternal mortality once you become pregnant is also reduced to some extent. Okay, what else has changed? Now, a whole lot of other things have changed, and we've heard that, and Sham showed a few slides, John showed a few slides. One of the problems we have is attribution. Can we attribute these changes and reductions in maternal mortality risk to these other social contextual changes? So we can attribute some of them, and others I think we could do a lot more to really try to do that. Shams has shown that access to facilities for any kind of healthcare has increased dramatically. Now, there's been major investments in upgrading of roads. There's a massive upgrading. Excuse me, I need a glass of water. Can I get a glass? Somebody here. Now, the assumption is that, okay, if there's a big improvement in roads, therefore people are using them, but we haven't actually done that kind of analysis yet. Excuse me. Thank you very much. Similarly with mobile phones, in 2001 there were about 1.5 million mobile phones in the country. By the 2010 survey, there were 67 million. Now in 2013 there are 100 million. So we know there's been a massive increase in the ability to communicate, but we haven't seen any research which demonstrates that these mobile phones have been used in a way which results in a reduction in maternal mortality. But it probably has, but I think there's a lot more we need to do to understand that. Television, for example, we've seen that the ownership of television has increased dramatically, and we can see simple relationships, associations between owning a television and using maternal health services like ANC. The question is it causative, or is it just an association working through economic status? Now, something else has changed, and this is what this presentation is really supposed to be about, is education. And we heard a lot about education this morning in the introduction from South Africa. So you can see here in this period from around the early 90s to 2000 or so almost 2 decades, there's been a halving of the proportion of women of reproductive age with no education. And I've used the word illiterate, but that's, as we heard this morning, illiteracy is a bit dodgy. You can assume that women with no education are illiterate. You can also assume that some women with incomplete primary are also illiterate. But anyway, there's been a massive increase in secondary schooling here. And this has been a result of, sorry. The present government was in power in the 90s, and they invested enormously in female schooling. They made primary schooling free for girls. Then they raised the level up to level 8 to be free. Then introduced a female secondary school stipend scheme which paid parents of poor households to keep their daughters in school through secondary school as long as possible. They had to maintain a minimum grade of about 45%, and if they became married, they would be excluded from the scheme. So there was an incentive not to marry the girls off prematurely. And that had a big impact. Now, I'd argue a little bit with Professor Kovodia that a lot of this secondary schooling is of extremely poor quality, but I think it has a major impact on the ability of these young women to negotiate the use of maternal health services when they become pregnant. The simple fact of just going to school changes the relationship with older members of the household. And to some degree it raises awareness. Now we're looking for indicators that that's really true. If you look here at, for example, awareness of obstetric complications by education and by over time, there appears to be a fairly substantial increase in birth planning. In a 2001 survey, we interviewed women who were in the 3rd trimester of pregnancy, first pregnancy, 3rd trimester. 70% of them had never discussed any kind of birth planning. They didn't know where they were going to deliver. They didn't know what they would do if they had an emergency that required funding. They didn't have any transport arrangements, nothing. They had absolutely no discussion about what would happen at delivery if there was a problem. And this, to me, this is one of the key indicators of change, that now they're starting to be aware of these complications. They're starting to have discussions about planning what happens if there's a problem. If I start hemorrhaging, where do I go? Where do I get money? Who can I borrow from? Who has transport? Which facilities can help me, and so on. So it's starting to happen. It seems related a bit to the increase in education. What's interesting, I think, about these mass education programs is that historically, before we had those programs, if a young woman had high level of education, almost invariably she came from a wealthy household, and probably her parents were reasonably well educated as well. Now with mass education, you get young women in the secondary schooling category who are a mix. Some are from wealthy backgrounds and well-educated parents, but a lot of them now are from uneducated parents and poor backgrounds. And we don't really know whether, if you transport a young woman from a poor, illiterate household through education into that group, whether they carry their parents' values and behaviors with them, or whether they rapidly adopt the behaviors, preventive behaviors and healthcare behaviors and all that of this well-educated cohort that they've now entered. Now, there are ways we can look at that, and particularly in a surveillance site like we have in MATLAB, where we now have 4 generations. So we can select out young women who are well-educated from well-educated parents and from illiterate parents, and see how they behave. We haven't done it yet, but we should. John, we should. Okay. You find the funding and we'll do it. Okay. So just because we are meant to be looking forward here into the SDG component here, we've been doing projections and just trying to simulate what's likely to happen over the next few decades. And I think we can fairly reasonably project what's likely to happen to at least the quantity of education, if not the quality. And then you can start to kind of decompose again what we're likely to see with a reduction. As I said, the number of births will decline from 3 million a year at present here to about 2 million a year here in 2030 or so, and even less up there. So the simple reduction in births will reduce some maternal deaths, not MMR, but some maternal deaths. and then how that interacts. But remember, when you increase education, if it's going to reduce maternal deaths, it has to operate through some mechanism. So either these educated people have to behave differently, so it has to work in some other way. It'll work through reducing fertility, it'll work through better access to healthcare, assuming the healthcare system works. And then there'll be some reductions within the MMR risks themselves, presumably. Okay, so just to wrap up, this is achieving, I forgot to write what this means, but it's ending preventable maternal mortality. Probably everybody in the room knows that. As you heard in the morning, I think hemorrhage is our major killer. A third of all maternal deaths are due to hemorrhage. We don't really have functioning blood banks in the country, and that's a major problem for hemorrhage. And we've seen we have qualitative components added to the 2010 survey, which just showed what happens to young women who start hemorrhaging. And as you know, you don't have much time. And so part of the messaging during pregnancy is to tell them, if you start hemorrhaging, go to this facility. But time and again, when we interview households where a woman has died of hemorrhage, she's been to the facility that she was instructed to go to, or the family's taken her there, but there's been no staff, or there's been no blood, or there's been no reagents in the lab to do the blood grouping that's necessary, and the cross-matching and all that. So we still have a major problem that our response to hemorrhage is dysfunctional or non-functional in many cases. Personally, I think we have to find another way around that in the short term, maybe using virtual donors or living donors and sort of buddy systems. And now with mobile phones, you could do that. Every pregnant woman could have the mobile number of a couple of other, they don't have to be women, they just have to be the same blood group, compatible blood group, but a couple of other people who are willing to donate if she needs it. Because it'll be a long time before we have functioning blood banks. As Shams mentioned, the indirect obstetric causes are now a third of all causes. We're starting to pick up things which could be intervened, like hepatitis E. We've only just recently discovered that a large number of pregnant women in Bangladesh are dying of hepatitis E. Or they have hepatitis E at the time they die during pregnancy. It appears to be that the infection seems to be exacerbated by pregnancy, like malaria is. So there's a vaccine in China which is not FDA approved, but we're trying to find out whether we could maybe vaccinate with hepatitis E vaccine during pregnant women. We know that the access to services 24/7 is very limited, and that's something that should be relatively easy to fix. But there's a lot of arguments about whether should we use midwives, can we get enough obstetricians and anaesthetists? Probably not. If we do get enough obstetricians, can we keep them in rural areas? Probably not. Okay, and then access, and then in hard to reach areas, maybe this emphasis on community-based skilled birth attendance, which is a major polarizing argument across the country. So some groups think we should have, because we only have a third of deliveries in a facility, therefore we need to provide people to go to the home with some training and skills. Others say that won't help unless you have facilities to refer them to if there's a crisis. Both of which are true. And then transport options. And then the last one, addressing weaknesses in the current regulatory policies for the private sector. So we've seen now this very rapid blossoming of private clinics, many of which are actually run by government doctors in the afternoons and evenings. And you'll even see women going to a government facility in the morning and being referred to the private by the same doctor. Come and see me in my private clinic in the evening. And this is extremely lucrative. I thought I had some numbers back there on the cost, but delivering in a private clinic is about 3 times the cost of delivering in a public clinic. And the other worrying part of this, which is totally unregulated, is that now close to 75% of all deliveries in a private clinic are done by caesarean section. And that is seriously expensive and often unnecessary. So 75%. Nationwide, 50% of facility deliveries, 52% of the last check are done by caesarean section. So this is a procedure which is extremely lucrative, mostly unnecessary, and just totally out of control and unregulated. So this is something to be a bit concerned about, I think. Last slide. As I mentioned, there are some other non-maternal deaths where we have vaccine preventable, HPV and hepatitis E. Screening of these conditions will be expensive, and we didn't talk about this much, but about financial mechanisms. Shams talked about it a bit, and he's a big fan of insurance. Now, there are experiments going on with insurance which may come to something there. In a country which has problems with administering very large numbers of very small payments, which is what this involves, you have all kinds of ways in which these payments can go astray and be misused and so on. So we have to find out a way in which it's reasonably corruption-free. And then, as was mentioned earlier, domestic violence is a major one. So I've spent 15 years in the MATLAB DSS, where we have a very large number of reports of young women committing suicide, particularly a short time after marriage. We know for sure a lot of them must be homicides, but nobody wants to report that, of course. And strangely enough, this problem of female suicide is very high in the west of the country and very low on the east of the country, for reasons that are not entirely clear. So we need to understand much more about these indirect causes of death to women of reproductive age. That's it. Thank you.